Once again, thank you for those kind introductions. And I'd like to show my appreciation to the organizers once again for this opportunity to share some of my views on inotropes and vasopressors in cardiogenic shock. I have no disclosures relevant to this topic. Cardiogenic shock is actually a very serious or lethal disease, and it's sort of clinically defined by a state of reduced cardiac output with end organ hypotension. It can range from mild hypotension to profound shock and multi-organ dysfunction. The general sort of accepted criteria for cardiogenic shock is a systolic blood pressure of less than 90 for greater than 30 minutes, or requiring vasopressors to achieve systolic blood pressure of greater than 90, a reduction of cardiac index, pulmonary congestion, and impaired organ perfusion. And although there is no sort of fixed diagnosis for this, I think across the different studies and the different societies, you can see the unifying theme across is that a systolic blood pressure of less than 90, signs of hypoperfusion, and signs of pulmonary venous congestion. Some of them, like the ESC, require laboratory evidence of hypoperfusion as well. But I think we're all talking about the same sort of group of patients. Now, it is a leading cause, especially from a cardiology standpoint, is in the setting of acute myocardial infarction in hospital. It is a leading cause of death. Its prevalence range from about 6 to 10% of patients with acute myocardial infarction, and the elderly patients, the prevalence increases to 7 to 12%. The good news is that due to the advances in critical care and care from 2003 to 2010, studies have shown that the mortality has actually decreased from about 45% to about 35% actually. And of course, if you are of the higher age, the risk for mortality increases to about as high as 55%. And this is kind of reconfirmed in the intra-aortic balloon pump shock 2 trial, which showed a mortality about 40%. So that's kind of between 35 to 40% is kind of the mortality rate in these patients. So as you can see, this is a very lethal disease state actually. Now the general principles of management is relatively straightforward. Based on the shock study, if there's any signs of ischemia, early revascularization is the key. Before the shock study, there were people that believed that, we should stabilize these patients and before we bring them to revascularization. But I think the shock study clearly tells us that, in these patients with ischemia, early revascularization is the way to go. And as with other critical care patients, maintaining ventilation, maintaining euvolemic, and then the use of inotropes and vasopressors to prevent long-term multi-organ dysfunction. So this is kind of a summary of potentially the different scenarios of cardiogenic shock and especially more for what we see in the CCU rather than a medical ICU. And so, if you have EKG changes, troponin, clinical symptoms suggestive of acute coronary syndrome, I think all of us would agree, proceed straight to the cath lab to sort of revascularize the patient. If the echo shows like complication after post-MI or VSD or severe MR, those patients should be brought to the OR, especially for VSD, even though they are really sick and high risk. Medical therapy, it's a really poor prognosis, and almost 90% of them would have a risk of mortality in 24 hours actually. And the rest is if they have respiratory distress, of course, you ventilate them to try to maintain their oxygenation. If they have kidney injury, you try to optimize hemodynamically. They may require renal replacement therapy for a short period of time. And of course, if they have hypoperfusion, the current recommendations, and I'll show you some evidence for that, is to actually use inotropes first, plus or minus vasodilators. And if patients are stable, we should wean them off as soon as we can. And of course, if they are unstable, then one may consider LVAD or ECMO. So those are kind of the general guidelines, sort of as the approach to management of these patients with cardiogenic shock. And as you will see in my remaining slides, there is actually not much randomized data to actually convince us or to guide us one agent versus another agent. There's some hints that certain agents may be more deleterious, but really a lot of it will be on your experience with those agents and on how your individual patient is and what is the best combination for them. So this is kind of a summary of the inotropes or vasopressors that are currently used. The list on top, these are the what they call vasopressors and inotropes. And then the list below here are what they call dilators. So they have inotropic effects and they are actually vasodilatory. So dopamine supposedly has sort of 3 distinct doses that might have different effects. You have the low dose, which activates the dopamine receptors, and this might improve renal function, what we call renal dose dopamine. But I've shown data from our Roe study that that may not be very specific, actually. Then if you're giving the mid-range, it activates the beta blockers. And then if you give a high dose, it activates more the alpha blocker, a pure vasoconstrictor. You have the norepinephrine, more vasoconstrictor with the alpha, may have some effects on the beta blockers as well. Epinephrine, on the other hand, more beta blockade and also alpha blockade. Then phenylephrine is a pure alpha blocker and without much or no effects on the beta blockade as well. And then vasopressin, that stimulates the vasopressin receptor. It's purely a vasodilator. Now coming down to the inodilators, so all these agents have inotropic effects, but they also have vasodilatory effects. So you have dobutamine, a beta, and it has vasodilatory effects. You have isoproterenol, beta blockers as well, beta agonists. And then you have mirinone and edrinone. These are PDE3 inhibitors, and they have inotropic effects in the heart and vasodilatory effects peripherally. And levosimendan, this is a calcium sensitizer and also has vasodilatory effects, lucitropic effects, and inotropic effects. Fortunately, this agent is not approved by the FDA, so we have very little experience with that in the US, but I think in Europe and the rest of the world, it's been used quite widely. So this, besides the shock study, the SOAP-2 study is one of the few large randomized clinical studies to compare different therapeutic strategies in patients with shock. So it's a multi-center randomized study. They took roughly about 1,600 patients, but they took patients, all comers. These are not just cardiogenic shock. So they include patients with septic shock, hypovolemic shock as well. And they randomized half the patients to dopamine and half the patients to norepinephrine. And if you look at the table, figure 2 up there, there was no difference in sort of mortality, survival between the two, although there might be a trend that dopamine may be slightly better. But when they did a subgroup analysis, they found that those with cardiogenic shock seemed to do better with norepinephrine compared to dopamine. But this is sort of a subgroup analysis, and hence one should take it, interpret this cautiously. But they did show that patients that were on dopamine had more arrhythmic events compared to norepinephrine. So, and that is not surprising based on the fact that the dopamine at doses can activate, have sort of chronotropic effects as well. Now, this study, although it's a multi-center study, but really a pretty small study, 219 patients, and they compared adrenaline or epinephrine to the rest of the vasodilators. So they included all other vasodilators and compared with adrenaline, and they showed that this small study, but the survival was worse with adrenaline. But interesting, when they compared noradrenaline with levosimendan or with dobutamine, there was no difference in the mortality rate. So this tells us, first hint that epinephrine maybe, or adrenaline may be worse off than norepinephrine in patients with cardiogenic shock. This is a recent study, which is sort of a randomized study, follow-up just published last year in JAC. They randomized, once again, very small study, only 57, and one of the reasons is because this study was stopped early by the DSMB. It's two-arm. They randomized them to epinephrine and norepinephrine, and what they found was that the incidence of refractory shock was higher in the epinephrine group compared to the norepinephrine. And this led to the early termination of the study, actually. And they also found that there was increased lactic acidosis in the epinephrine group as well. So this is a randomized study, although small, but suggests this one again that epinephrine may be detrimental compared to norepinephrine. This is a meta-analysis. So they looked at 14 studies looking at epinephrine use and mortality, and they came to the same conclusions as the two previous studies, that patients that were treated with epinephrine had increased risk of death, actually, compared to other vasopressors. So moving on to some other comparisons. Once again, like I've mentioned before, all the studies are rather small, so we need to interpret some of these results with a bit of cautious. This is a retrospective review, so they looked at 50 patients where mirinone was started and 50 patients where dobutamine was started for cardiogenic shock. And what they found was that there was no difference in hemodynamic changes, and the percentage of resolution of shock and the time to resolution of shock was similar between the two groups. But they did find that patients that received mirinone had increased incidence of hypotension, which is not surprising based on the biological effects of mirinone. And patients that was randomized to dobutamine had increases in incidence of arrhythmias. But overall safety profile was similar between the two. So this suggests that, as we decide between mirinone and dobutamine, we have to take into consideration the individual patient. If somebody is more hypotensive, one might use dobutamine first, and if somebody is sort of more vasoconstricted, one might consider using mirinone first. And then this, once again, another study that compared levosimendan with enoxamone, which is similar to mirinone. 32 patients, so very, very, very small study. And they sort of, in this small study, found that levosimendan may be better than mirinone. So, mirinone and enoxamone. So once again, very small study, but may suggest that levosimendan is better. However, when the manufacturers of levosimendan was trying to get it approved in the US, they carried out this moderate-sized randomized study called a SURVIVE study, comparing levosimendan to dobutamine in patients with acute decompensated heart failure who required inotropic support. They failed to show any survival benefits, actually. Hence, because of this, levosimendan was never approved in the US. Now, this study is interesting. It tests more the strategy rather than individual agents. It's an observational sort of retrospective study of 1,000 patients. And what they found was that if patients were on inopressors or vasopressors alone, compared to patients which have inopressors and inodilators, so the patients that were on vasopressors alone tend to do worse. So suggesting that one should either consider combination of inodilators with inopressors rather than inopressors alone, at least for cardiogenic shock. So, septic shock and all that that's a different pathophysiological process, and that would be require a different therapeutic approach. So I sort of summarize, like I say, we don't have one big study to sort of guide us. So from all these studies, my take from this is I think we have enough evidence to show that epinephrine compared to norepinephrine had worse outcomes and more adverse events. So I think if you need to use a vasopressor, I think one would pick norepinephrine first. I think the jury is still out between dopamine and norepinephrine, although the study did show that dopamine maybe have more arrhythmias, and in cardiogenic shock it may be less beneficial than norepinephrine. However, that was not the primary endpoint. So I think once again, one has to decide what is which sort of physiological properties do you want to get out of each agent. For example, if you have patients with heart failure and with worsening renal function, low dose dopamine may be more useful. Not evidence-based, but more physiologically based approach, actually. And apart from sort of one or two small studies that show that levosimendan might be better than dobutamine or minorenone, like I say, the SURVIVE study in patients with acute heart failure really didn't show any survival benefit between levosimendan and dobutamine or minorenone. So I think, currently we do not have enough data to recommend one of these over the other, and its use have to be sort of individualized. For example, dobutamine is more arrhythmic but less hypotensive, and minorenone is more hypotensive. So depending on your characteristics of your patient, you might decide one over the other. But I think from that one sort of meta-analysis, it showed that combining a vasopressor with an inodilator was associated with better outcomes compared to vasopressors alone. So I think there's at least a suggestion of that. So as we approach patients with cardiogenic shock, I always tell my fellows and residents, even with echo and with all our biomarkers, you need to examine the patient and you need to classify the patient. This is kind of a simple classification, and we use this in our heart failure patients as well. You can classify as according to the volume status. Are they wet or are they dry? And you can try to classify according to their peripheral vasoactive status. Are they cold or are they warm? So most of our classical sort of cardiogenic shock patients early on would fall into the wet and cold. So they are fluid overloaded. They have increased SVR, they have increased wedge. Sometimes, we do see patients who have sort of end-stage systolic dysfunction. They may not be wet, but the cardiac index is really low, and the SVR is high, so they're kind of cold, dry and cold. And then this is something that we don't see that often. The sort of wet and warm patients. These are patients that you guys may see more the sort of septic shock, sort of vasodilatory shock, and then this dry and warm. That is really doesn't fall under the cardiogenic shock category. So kind of these are just sort of rough guidelines, sort of or approaches that this is found in the AHA document. So if you have classic wet and cold, I think evidence should show that, an inotropic agent may be useful, unless, of course, they are hypotensive. Then you may have to introduce a vasopressor as well. And I think what was not put here is I think you should, of course, you need a diuresis patient as well if the blood pressure allows you. And in the sort of patient that are cold and dry, then these patients, I think inotrope plus a vasopressor, and depending on your assessment of their fluid wedge pressure, and then of course if you have a line in, you can do that easily. You might give them a bit of bolus, small fluid bolus, very cautiously as well. I'm not going to touch on the sort of vasodilatory sort of septic shock sort of issue. That's beyond the realms of this topic. I will touch a bit on RV shock. So we can see RV shock in the CCU not infrequently with patients with inferior MI. And if you diagnose that, I think controlling preload is important with fluid boluses. And if you need to, inotropes may help, actually. And so I'm not going to talk about. And so one thing that you need to kind of rule out before you sort of jump into using an inotrope, if you have any suspicion for LVOT obstruction, doing an echocardiogram will help you and guide your therapy, because the if you have LVOT obstruction and you use an inotrope, that will worsen your LVOT obstruction, actually. If you had to use a vasopressor for IVOT obstruction, phenylephrine is the best vasopressor to use because it has really no effects on inotropic properties of the heart, and that would ease up the LVOT gradient. And so let me show you. This is the echocardiogram, and this is the Mayo layout. The ventricles, left ventricles on the left, right ventricles on the right. And if you just focus on this mitral valve, you can see what we call systolic motion of the mitral valve into the LVOT, maybe seen better in this panel here below. And if you put on a color, you can see aliasing and turbulent flow in the LVOT. And when we put a Doppler through that, you can see a gradient across the LVOT. So if you diagnose this, this will help you manage the patient correctly. Giving inotropes in this patient would worsen the LVOT obstruction. So I just have two more slides. I'm just going to summarize what I think is the sort of at least my take from the current evidence. I think in a cardiogenic shock, I think the first line of therapy is that we should sort of consider inotropic or inodilators. And based on the evidence we have, I don't think we have enough evidence to guide us as to whether one of these agents are better than the other. So it needs to be sort of individualized depending on, like I say, the status of your patient. So if you have a patient that's more hypotensive, dobutamine may be useful. If you have a patient that has a lot of non-sustained VT and PVCs, then Mirinone would be a better thing, like I said. And I know levosimendan has a lot of nice properties, including lusitropic properties. And I know in the US now there's ongoing studies with levosimendan in patients with heart failure and pulmonary hypertension. But unfortunately, I personally have very limited experience with levosimendan, so I'm not going to comment so much on levosimendan. Small studies to show that levosimendan may be better than Mirinone. I think we await for the newer studies that are ongoing in the US now to see. So, like I say, depending on the state or the characteristics of your patient, levosimendan and Mirinone, more hypotension, dobutamine, more tachycardia. So you kind of need to individualize your use according to what characteristics your patient is. I think there is enough evidence to show that epinephrine has more deleterious effects compared to norepinephrine. So if you need a vasopressor, I think epinephrine is the way to do. The SOAP2 study suggests that dopamine may have higher rates of arrhythmia and maybe have worse outcomes in patients with cardiogenic shock. So I think But once again, that was not the primary endpoint. One may consider using norepinephrine instead of dopamine in that situation. But I think low-dose dopamine for renal enhancing, that is a sort of a separate property compared to using high-dose dopamine, as high-dose dopamine was the dose that was used in the SOAP2 study. I think one principle that we all agree is that the use of these vasopressors of inotropes should be restricted to the shortest duration, and so as soon as you can wean the patient off, one should do that. There is a new class of inotropes which is currently undergoing investigation for acute heart failure, and these activate the cardiac myosin. And at least phase 2 studies are promising, so we'll wait and see what the phase 3 studies show. So I'll end it and I'll take any questions. Thank you.
Thanks, Dr. CHEN, for a very enlightening lecture.